I celebrate Khiron House, and I'm delighted you're hanging in there and doing your work. And indeed, the question is, how do we let people know what a wonderful sanctuary you have created over there?
Well, it's always an interesting question. I think people have to do their explorations. They find things that resonate. I mean, when people come to us and they inquire, it's often because they have an assessment and they have that first encounter and they hear something new and it gives them hope. And this is how we know that people are going to progress, is that there's a brightening. They're like, oh wow, I've never heard of this stuff before. Yeah. And this makes perfect sense to me. So like a lot of people who read your book who say, this book gave me hope, this book changed my life, or even this book saved my life. Yeah. It's that same kind of thing where you reignite that spark. Yeah. That actually maybe there is something out there that can help me. And that's just such a wonderful moment.
It's, as our mutual friend Dick Schwartz likes to say, we are hope merchants. Very much what we need to do. And unless we explore new options, there is no hope, because many people have explored many options, and that's what our life has been about, is to, if at first you don't succeed, then see what else is available. And because of that, we have actually become aware of many different ways of helping people.
Hi, my name is Bruce Dixon, and I'm the CEO of the Trauma Research Foundation, and I'm delighted to be here today with Dr. Bessel van der Kolk and Benjamin Fry, the founder of Khiron Clinics, as they discuss residential treatment centers and how being led by external factors such as insurance codes, the DSM, and investment returns are the antithesis of how to provide effective healing for the body. Khiron Clinics strives to follow an alternative path, working inside out, starting with the body and then toward these external factors, which brings its own difficulties in a residential setting. The challenge may be to hold the paradox of both of these models simultaneously. Dr. van der Kolk and Benjamin, thank you both for being here. Benjamin, could you get us started by sharing what brought you to Khiron House?
Back in 2009, I was a practicing psychotherapist in Great Britain, but I also began to suffer from my own, in retrospect, what we might call nervous breakdown. Ultimately, I ended up having a brief stay in a psychiatric hospital in the UK, and then a much longer stay at an institution in America. And that's where I discovered the kind of treatments as a derivative of the idea that the body keeps a score. I discovered EMDR, I discovered somatic experiencing, first heard the name Bessel van der Kolk, Stephen Porges, Peter Levine, etc. I began this journey as a patient. I've seen the residential treatment center industry, if you like, from the bottom to the top and back again. It interests me. It interests me greatly how that works, how we do it, why we do it. And I know that the paradigm that Bessel has of the body keeps a score is in many ways kind of the opposite of the paradigm of the typical approach to residential treatment from large organizations. And I thought we might start by just touching in on the role that the insurance companies have to play in directing traffic, in directing treatment for these rather large, complicated and difficult enterprises, which is residential treatment.
You know, this is a very core, very complex issue, and that is that our field is basically a mess. People pretend like they know more about the mind and mental illness and all that stuff than we actually do. So my own particular journey, as they call it, has been to stick with the Hippocratic Oath and do whatever we can to get patients better. And so I've been very curious about what would work and what wouldn't work. But at the same time, we have financial aspects to the treatment that we do. And that is being held by insurance companies who need to make some decision about what they will fund and what they don't fund. And this is fairly arbitrary in a way. But the way that our field has evolved is that the decisions about what gets paid for are made by clerks in insurance companies rather than by people who would actually have a lot of on-the-ground experience. That is not helped by the fact that there's a tradition in psychology, psychiatry, to not to study outcomes. And so people make all kinds of claims about what works, but there's very little evidence. And I can proudly say that I've actually studied more different forms of treatment than anybody else alive for psychiatric illness. If that's not true, point out who has done more studies. Huh? So we started off with looking at Prozac and medications. That worked somewhat well some of the time. Then we learned about EMDR, and that was another new technique. Took a long time before that got welcomed in. Then we studied yoga, and it turned out that yoga was a very good treatment for PTSD, and actually so better than most psychiatric drugs. But I've yet to see psychopharm lab turn into yoga studio. So in some ways, clinical practice always runs way ahead of certainty. Clinical practice is very much an experimental practice where we learn what helps people, and there's on a case-by-case basis. And who can do that? People who have infinite resources. But the insurance companies don't reimburse for any of these things. So the way that our society is set up right now is that if you have a lot of resources, you can get the treatment that you need. But if you have no resources, you depend on insurance companies, will almost certainly not pay for the treatments that are most helpful to you. A place like the Khiron House that goes back to the idea of our job is to get people better, and our job is to explore whatever may work, is so refreshing. And a place like Khiron House can be a beacon of what is actually possible. A good example of how the insurance reimbursement issue gets in the way of people doing better is, for example, that some very good studies were done on neurofeedback and addictions in 1989, 1981. I don't think any addiction program does neurofeedback. And then in Khiron House, I told you guys, you really should be doing neurofeedback, so you started neurofeedback. And then insurance companies don't pay for yoga, but we did a study that showed that yoga really works. And then you guys are doing yoga with people, and you're doing somatic experiencing with people. But there is basically a real tension between what people get paid for and what the best treatments are. And the two of them are almost orthogonal.
Almost orthogonal is about right. I mean, tension, you mentioned, I think that I feel that very viscerally. Can I show you a diagram? We use this internally to try and understand these tensions, because tension is kind of everywhere. Rather than have a bunch of, how like you can see an organization chart, there's a bunch of like trees, like a family tree.
Yeah.
Try and think about it in a more integrated way. And if you think about it, I've experienced every place on this circle personally. And I come back to trying to make it about the place in the middle, which is the nervous system of the individual we're trying to treat. Now, if you take the idea, like in your book, that the body keeps the score, what you're really trying to place in the middle of this journey is each individual person's body. And then you think, well, what is the container for that? And usually it's the group of peers that they're in treatment with. And then what's the container for that? Well, it's kind of like the wider campus. Funnily enough, characters like the gardener or the driver can have a significant effect on the experience of people in these kind of treatment centers. And then how does that sit within a clinical operation, a clinical idea? And then the idea is, if you could establish all of that healthily, what would the operation of a place like this need to bring to those places inside the circle to make them work? And then how would the business hold this? And I think you can see that the tension, in a sense, is the direction of travel, ideally according to you and me, is out from the middle. But once you arrive at the outside, you basically created a business that probably doesn't fit into the business world outside of it. And I think this is exactly what's happening with insurance companies. And we experience this. We constantly trying to help people to get support from their insurance companies. And of course, insurance companies are pushing back. And, the easiest thing we could do would be to provide treatment that insurance companies pay for, but it's not what we believe in. And, I just wonder, if you look at this kind of idea, do you have any thoughts about where we could be doing things differently, or how we can mitigate the tensions that you get from one circle to the other, as it's simultaneously, when you say orthogonally, but actually what's happening is there are pressures coming from the outside in that compete with the needs from the inside out. Does that make any sense?
I think the ideal model will be a capitation model, like the Dutch insurance companies work with, that a doctor gets so much money to treat a particular patient, and then you can do what you think is right for that patient. So you get paid per patient and not per method. What is at the core, and that's missing in both our psychopharm model and our DSM model and our model of mental illness, is in some ways the trauma notion has really done some damage there, is that we're monkeys with a big forebrain. We are just a bunch of human beings who make their lives together. So DSM is very much based on this individual model. You're messed up and everybody else around you is normal. You're feeling unsafe. You don't make it with other people. And the core issue, what makes people feel safe, is being safe with other people and belonging with other people. And if you get too hyper aroused, if you get too terrified, too angry, too upset, you lose the capacity to make contact with other people. So at the core of it all should be, at that little circle you have there, is how do you help people feel safe and capable of being with other people? That's at the core. And so who pays for that is a whole different dimension. We're paying people per hour for a particular method. And because of that, a lot of things have gone wrong in our field. For example, you mentioned the issue of groups. The way Judy Herman and I both started our work in the trauma field is through groups, because we didn't know what it was like to be sexually molested when you're 4 years old, but people who have been sexually molested when they're 4 years old do know that, and they can communicate with each other. I started to work with people in the Marine Corps in America. I've never been a Marine. I've never been to basic training, but I learned a lot about what it's like to be a Marine by doing groups with them, and they felt understood by each other. And so this whole notion that people can be hooked up with people like them and learn from each other and form a support for each other, instead of that one-to-one, you and your therapist, is something that has been lost in our contemporary framework. Any good inpatient program is very much focused on group processes and learning how you deal with other people and how you take in the caring of other people and how you set boundaries with other people. So it is at the core of becoming mentally healthy. And those are all group phenomena. And so indeed, your model that you need to have all these different layers is absolutely correct. And only if you have a comprehensive treatment program that doesn't get cut down into little pieces can you provide a sort of treatment.
Well, I couldn't agree with you more. I mean, probably the thing that surprised me the most in my long stay as a patient in residential treatment was the group process and the group dynamic, and what it taught me about my own relationship with attachment. Now, I understood I had trauma, and we were beginning to understand about trauma methodologies, and we were understanding about things like EMDR, understanding about processing trauma and recovering from trauma. But what I didn't know and couldn't really have learned from a book or from an idea was how complicated it made for me to be with people.
Yeah.
Obviously, I was a functioning person. I thought I knew how to be with people, but I didn't realize I didn't really know how to be with people. Right. I knew how to interact with people. I knew how to get things that I wanted from people, or to present myself in a way I wanted to be seen, but I didn't really know how to be with someone. And the most startling thing I remember was an experience of, we would do kind of like housekeeping as a group, as a community every morning and every evening. And so we'd be encouraged to bring frustrations and bring difficulties. And I had to, on one occasion, bring something to someone that I really didn't get on with. I really didn't, I didn't like her. We wouldn't have been friends in the outside world. And it astonished me how close and connected I felt to her when I was able to articulate my own difficulty, but to do it in a way they taught us to, which was safe, respectful, and owned. It's very much like, this is my experience, it's not your problem. And that was astonishing. And that's not on the list of, even if we drew up a list of great methodologies, that's not in the neurofeedback bag, that's not in the EMDR bag, it's not in any bag.
That's right.
Actually, it's a function of being in treatment in a different way. I mean, this is the remarkable thing about residential treatment, is that you get access to a whole different paradigm, a whole different area. And with skillful clinicians who understand that attachment is related to trauma and relationships are related to trauma, and that we all inevitably, because we're living in one campus, have relationships. There's so much opportunity there. And what's sad is that is often devalued by the client when they come in. They say, I don't want to go to groups, I just want therapy. It's not particularly understood or valued by some of the outside stakeholders. And certainly it doesn't really make a dent in the insurance picture. Or in the UK, we have this NHS, National Health Service, and they have their own guidelines. And it's almost like it's not complicated or interesting enough to be valuable. And yet it's so central to the experience of feeling safe. I mean, I've never felt so safe as I did, in that facility. Yeah. And that's the beginning of them being able to be available for treatment. So there's something very frustrating and difficult about knowing, like from my body out, and our clinicians feel the same, that it's those close feelings of becoming safe in a community then facilitate everything that ripples out. But when you get to the outside, if you started there, you have people saying, look, the problem is you need a categorization. Is this borderline or is this bipolar? And then if it is, then you must do this, you must do that, you'll get paid for this, you get paid for that. None of that ever speaks to community or safety. And I find that, that's difficult because on the one hand, as you say, financial outcomes are important. You're not going to get anyone well if your facility goes out of business. And the easiest business there is to run the business that people will pay for. But it's not the business of helping people and healing them. And that's a real conflict.
Yeah. So basically, I'm thinking about so many people who I see and supervise on, who grew up in families where they never saw a decent conversation, where they never saw people negotiate conflicts, where people never had a good conversation about differences of opinion, where people actually paid attention to each other. And then they may have been working through school and they get a degree, but they have never learned how to be a human being together with other human beings. And that leaves a tremendous deep sense of devastation inside of you, because at the end, human life is all about love and connection and feeling safe with people. That's what life is about for human beings. And so as long as that's missing, you feel terrible about yourself. And so learning how to be with other people and negotiate your needs and to have reciprocal relationships is so important. And individual therapy, for example, is not a reciprocal relationship. Therapists love to talk about relationships, but a therapeutic relationship is not really a relationship because one person looks after the other, but it doesn't go both ways. And in real life, people need to learn for each other and negotiate to be in pods and in pairs and in groups and to take your place in a group and to feel good about the group you belong to. And at the end, feeling that you belong and your body belongs in this place, your body feels good in this place, is at the core of what makes life worth living.
The client's needs are the client's needs. They never change. I mean, the body is the body. And the mitigating factor between these two orthogonal axes is actually human beings trying to deliver treatment. What could we say to those people? What can we say to people in that clinical, in that community, in that group setting who are literally being pulled apart from one side to another? Yeah. I mean, where is the hope for those people in that? Because they're everywhere. They're everywhere.
Yeah. It brings to mind, I have a friend, Barry Walker, who teaches me in Australia these days. People asked him, what is necessary to become a really good therapist, a psychedelic therapist in this case? He said, number one is become a waiter and learn what it's like to really serve other people and and to be there for other people, even though they're obnoxious and unpleasant. That's the first thing you need to learn. Second, learn to play musical instruments and play music with other people. Number three, learn a new language. So, and I thought that's just a brilliant advice. The core issues, you need to do all three of those dimensions in order to do good therapy. You need to learn other people's language, and you need to learn to make music together, and you need to really serve people completely. Yeah.
At the same time, a lot of therapists doing that, whether it's in a residential setting or not, are under the auspices of larger themes, which are saying you should do this, you shouldn't do that, I'll pay you for this, I won't pay you for that. What do they do? I mean, what do they do when they know that the instructions they're receiving don't match up with exactly those skills which was mentioned?
What I see a lot is therapists who burn out and who are working on the outer circles and give people advice on how to manage their lives. I gave that up a long time ago. I think trying to manage somebody else's life is completely impossible. I like to say I can barely run my own life, let alone running other people's life for them. But I can certainly help people to figure out how they can learn to manage their lives. But I think what passes for therapy these days oftentimes is giving people advice about what to do or to how to deal with external circumstances. And therapy is really about getting to know yourself and getting to handle yourself and getting to take care of yourself. And taking care of yourself means also being able to be with other people in a mutually satisfying way.
What would you say to, I mean, some people listening to this might be relatives or might themselves be people who are thinking about residential treatment for themselves. Given that there are these recognized conflicts, these recognized difficulties in the field, what would you suggest to people to look for if they are in the position of feeling like they need to look for residential treatment for themselves or for someone they care about?
You know, I think there's definitely a role for a residential treatment, because sometimes people just need to have a very deep experience of how else life can be. And then the big problem is, where do you go?
Yeah.
As you also have discovered, oftentimes it's not mental health institutions that really help you to go there. Sometimes it's a computer camp or archery camp or going canoeing with people for a week or whitewater rafting. Or it's about having communal activities with other people where you get a new perspective in yourself. How do you find a place like that? I think that's very difficult. I think it's by and large word of mouth. When I look up these sites of various people, and people give all their degrees and what they've done, but they don't tell me much about what we're going to do together. And I think what's really important for people to be aware of, how can we will teach you how to regulate your body and to feel at home in your body and to move in a way that feels safe, being safe with other people. And we'll help you to really explore what's going on with you and to help you to understand your patterns and help you to create new habits. And we can explore with you what new habits are useful for you.
One of the interesting things that we see is that people will approach us with very complicated problems that obviously are in their conception of it located in the head, in the mind. And then we're asking them to do things like go to group sessions. We're asking them to do things like movement, yoga and Tai Chi and mindfulness and meditation. And it's been very difficult to, initially for people to join the dots on this. Why would that be relevant? This is why I think your book has been so helpful, because it's allowed people to understand that even from the summits of psychiatry, you can look into the body and validate the body as important. But I think there's something tricky about it, because if you're, say, the parent of a 22-year-old who's having a nervous breakdown, and you know nothing about any of these things ever,
right?
Surely the most reassuring thing is to go to a hospital where a doctor says, we know what's wrong, and they just need antidepressants and CBT and they'll be fine.
Right.
And that's very seductive. Whereas if you come to, someone like myself, I'm not a doctor, a psychotherapist and I have a different story to tell and it all sounds a little weird and woo-woo. That, I mean, most of our patients are people who've been through hospitals or been through rehabs before, at least once, and they begin to realize that it's actually not scratching the problem, not scratching the itch. And then they start looking around and they discover things like your book or other influences, and they look for something that can deliver that. How on earth can we move forward from this kind of hierarchy, these institutions, this sort of DSM hegemony, to a place where your kind of work is more, people understand more that that mental health is an idea, but really the whole body is involved.
Yeah, but you're talking about sort of inevitable. Huh? We all have hierarchies in our minds, and our society is hierarchy. So if something comes out of Oxford or Harvard, it must be good. And if something comes out of Wickenburg or Fargo, it cannot possibly be good. And so that's the default mode you go to for prestige, because what else do you go by? And I think it's important for us in how we present ourselves as resident treatment programs to really show what will we do with you. We will help you to feel comfortable in your body. We help you to actually able to have fun with people, to feel mutual affection and commitment to other people. We'll help you to negotiate conflicts. We'll help you to stand up for yourself without being terrified that you may forever be rejected. We'll help you to calm yourself down and sort things out in your mind. But it's very much on your mind, what that you need, and we'll be very specific about. There's no cookie cutter approach. One size doesn't fit all. We'll go to really find out what is getting in the way for you. You and I will find out what we need, and then we'll tailor make a program to help you to have a fruitful and satisfying life.
The problem that we see evidenced often in kind of residential treatment centers, which is that it's driven from the externalities in, is a mirror of our own predilection to prioritize institution externalities, things that we can hang our hat on and say, that must work because that's from Harvard or that's from Oxford. And that we've learned to devalue our bodies. And in the same way that our institutions are mirroring that because they've learned to devalue the individual's felt experience. And instead they're wrapping around it kind of codified methods of providing treatment for all at the expense of the individual and their embodied experience.
But as you know, from your own experiences, both on the consumer and the giving end, residential treatment settings are a life apart. And I think you're already saying that. I was the last director of Boston State Hospital, once a very venerable, gigantic mental hospital system. And my first job out of my residency was actually to run an institute for extremely mentally ill people. I loved it because nobody expected us to cure anybody. We just had to make their life as good as we possibly could. And boy, we really worked on creating a good life for very impaired people. That was, I don't write about that in my book, but it's a very powerful experience for me, actually. And I remember I inherited two Black women who probably never finished high school, who were just unbelievably thoughtful clinicians on the ward who could really work with extremely disturbed people. And to work together as a unit and to see everybody work together and to eat together and to have group therapies together, it creates a whole atmosphere away from the world out there. And really, you can focus on how can we work as a unit? How can we really bring out the best in people? And to some degree, a residential treatment program, as I see it from my somewhat romantic notion over many years, is to some degree, it protects both patients and staff to some degree against the demands of the outside world for profit and prestige.
Well, I think that's a really prescient point. And I suppose my fear and my experience on occasion as a patient was it's the other way around.
I'm sort of a rebellious guy by nature. I've always been that, and my generation was a rebellious generation. But I'm astounded by the passivity of clinicians who are allowed themselves to be dictated to, and who don't value themselves enough to say, no, I know what this person needs, and I cannot be subscribed to you. Let me tell you what this patient needs. And I think clinicians really need to work together to put this world on their head and say, no, I'm going to dictate what this person needs and not my insurance carrier.
Sure, but don't you think there's a great asymmetry of power, typically in the way that the treatment center world is set up? The owners, the investors, the insurance companies appear to have all of the money and all of the influence, and the clinicians who are at the coalface, who are close to the body, close to the nervous system, are having less influence, less say. Look, in our case, I mean, we're lucky. I'm the only owner, if you like, of our treatment center. And I've been a patient, I've been a clinician. Yeah. There's still probably people who feel like there's things they would like to do differently and that they like to stand up to me. And that's probably even difficult in that context. Imagine if, instead of being a human, I'm an investment committee or an insurance code committee. I mean, it's tough. But it's interesting because in some sense, what we're talking about like the inner world of the patient, if you like, arguing for the treatment that really works for them. And then you're talking about like the activist in the clinician arguing for the liberty to provide the treatment that these wise organisms really want. And it's kind of like from the inside out revolution of people just trying to push back, so that you can communicate to the outer edges of this ecosystem what's really needed and what's really necessary. Why do you think it is that in the research world, a lot of the research that has been done has actually pointed to a different direction, where you create a kind of superstructure that says this works for everything, or this is the best thing to do. And that's placed on the outside and kind of squashed into the clinicians and into the clients and patients. Where's the disconnect? I mean, because they're researching the same people.
I know this from the inside out. So 1980, the DSM gets the PTSD diagnosis in. Nobody knew anything. It's only 40 years ago that we simply did not know anything about trauma. And then we went to work. And we said, talking actually is helpful for people. EMDR is helpful for people. Maybe moving together is helpful for people. And so you gradually discover what is helpful. And so it's a journey of exploration. And what happened is that as long as there was no money, everybody's making a living seeing patients, being a clinician primarily. And then money started to come in the field, and the field got split between researchers and clinicians. And I and Wendy D'Andrea and Ruth Lanius are among the very few people in the world who are solidly clinicians who are also researchers. Yeah. And we learn how our guides are our patients who we need to treat. And our guides are not primarily what NIH will fund at this particular point for research. But once you become a full-time researcher, your main interest is to keep your lab going. And so then your main interest becomes, where can I get the best money so I can keep my laboratory going? And then you become part of the political system where whatever is prevalent in terms of getting funded, which for the longest time was psychopharmacology. And as I started off in my career also, I did the first studies on Prozac, first study in Zoloft. I started off as a very respectable person. Because that's where the money was. And then I realized they don't work all that well. And then I started to see what else is there. But that meant that you don't have a lot of time, you don't have money to pay people because you're going to do new things. But that's an edge you need to want to live on in order to explore new possibilities. And if you go for safety and security, you go with what gets funded already. I always went for stuff that had not been done before. I did the first EMDR study, first yoga study, first theater study, because I was curious what else there might be. And somehow for me, it actually paid off. not financially, but in terms of being able to create these things, because I and the people who worked with me were adventurous spirits.
Well, look, I can relate to that. I mean, we've had many times I can think of, we've had a client or resident or a patient who's needed something, and someone's come to me and said, seems like we need to kind of do this or do that or do the other, but is that right? And could we get in trouble? Maybe we might even get sued. And I always say, I don't care. I don't care if we get in trouble. I don't care if we get sued. Is it the right thing for that individual person? And they say yes, and so we do it. But there are few people like us who are sort of naturally rebellious and willing to stand our ground. And are you saying that there are these twin tracks, in a sense, in our field of research, which kind of has that whiff of conforming to something or paying lip service to something else beyond what is pure research? And then there's kind of this plucky band of rebels like Khiron Clinics or, everything you were doing. And why is that just the nature of man, if you like? This is the setup of our internal hierarchies. There are some people who are going to go out and try and do it differently. And maybe if they're lucky, they end up, like you, actually becoming part of the establishment and really making a difference and really changing the landscape.
People have always needed sanctuaries. And from time to time, people become aware of that. I think for me, one of the great messages of COVID was that all of our treatment centers shut down and all of our sanctuaries shut down. And like at this yoga place that we teach at here, Kripalu, shut down for 3 years. And Esselen, where we teach regularly, shut down. And that brought home for me again the essential nature of asylums, of sanctuaries. And asylum got to have a bad name, but asylum means a place where you can feel safe. And I think what all of us need is we need to have sanctuaries. And that's where we should go and treat mental illness, or disturbances or whatever, to take time out. It's also an old religious tradition. In India and Japan and Europe, people go on pilgrimages and they spend months or years just seeking God or seeking satisfaction. It's a part of life.
Well, I couldn't agree with you more. I mean, I had the experience of needing to find sanctuary halfway around the world, and it left, a deep mark on how hard it was to do that. And as a result, one of our policies is we fly people from wherever they are to our clinic in Oxfordshire, just because, I just believe that the body wants to be held from the moment they leave the door to when they come in. It's hard to make those journeys, if it's around the corner or if it's in another continent.
We need to find a place where we can go, and when you're very traumatized, the whole world is a scary place, and so we need to really ramp up that sanctuary thing, but to really make it sure that you're safe over here, and you can really take time out to really feel who you are, and to take care of this creature who you are.
Yeah. Well, I guess I'd just like to thank you very much for helping me and the team create that sanctuary for others. As you said, it's incredibly rewarding work. You are, for many people, their hero. For me, you're one of my heroes too. So hopefully you'll accept from the plucky rebels a bit of self-esteem from our side.
I celebrate Khiron House, and I'm delighted you're hanging in there and doing your work. And indeed, the question is, how do we let people know what a wonderful sanctuary you have created over there?
Well, it's always an interesting question. I think people have to do their explorations. They find things that resonate. When people come to us and they inquire, it's often because they have an assessment and they have that first encounter and they hear something new and it gives them hope. And this is how we know that people are going to progress, is that there's a brightening. They're like, oh wow, I've never heard of this stuff before. Yeah. And this makes perfect sense to me. So like a lot of people who read your book who say, this book gave me hope, this book changed my life, or even this book saved my life. Yeah. It's that same kind of thing where you reignite that spark. Yeah. That actually maybe there is something out there that can help me. And that's just such a wonderful moment.
It's, as our mutual friend Dick Schwartz likes to say, we are hope merchants. Very much what we need to do. And unless we explore new options, there is no hope, because many people have explored many options, and that's what our life has been about, is to If at first you don't succeed, then see what else is available. And because of that, we have actually become aware of many different ways of helping people.
Well, thank you for carrying the candle for the hope for us and many others. It's great to talk to you today. And I'm grateful for your reflections on this complicated project.